So it gives me a lot of pleasure this afternoon to introduce Dr. Perry Kendall. So Perry's a community medicine specialist who's held a number of senior leadership positions in public health across Canada, including working as a medical health officer in Victoria and Toronto, as a manager of disease control and epidemiology services within the Ontario Ministry of Health, and as the CEO of the Addiction Research Foundation of Ontario. Since 1999, Perry has been the Provincial Health Officer for British Columbia, and in this role he acts as an independent advisor to the Minister and Ministry of Health and to the public on public health issues and population health. Perry is a really strong advocate for issues related to health vulnerabilities, addictions, drug abuse prevention, HIV and AIDS, and in 2005 was awarded the Order of British Columbia for his contributions to public health practice and to harm reduction policy and practice in BC. So please join me in welcoming Perry Kendall. Thanks.
Well, thank you very much, Mark, for the introduction, and I'd like to thank the organisers very much for the invitation to speak and the opportunity to speak. I would also like to acknowledge that I got a lot of help in putting this presentation together from Rick Marchand, from Mark Gilbert, from Terry Tressler, and from Stephen Smith. And so if you, to the extent that you find this useful and a contribution, I would like to acknowledge them for that. To the extent that you don't, you can blame me for it, okay? I think that'll be fair. And the issues that I'm going to touch on will reflect, I think, many of the issues that Philip and Brian talked about earlier. So in fact, I may skip over some of the slides because I think they dealt with them better than I possibly could, and also in interest of time. And I'd like to say that I'm approaching this, I guess, from the aspect of the public health practitioner. So the one question that I think it was Philip didn't answer, the public health one, perhaps I'll fill in some of the data on that and hence complement their really excellent presentations, I thought. So just the outline of what I'm going to talk about is in 4 parts. The first part considers the current, well, it's some measures of the current health status of gay men in BC, defined perhaps more in terms of gaps than in resiliences, because we're looking at disease and some deficits. And I'm going to touch on prominent health issues, prominent disease issues that form a large part of driving the gay men's health agenda, the current state of where these issues are at in BC, and emerging health issues or challenges that you might want to consider in the future. Second section's going to look at some of the environmental elements or forces that may influence or that do influence specific vulnerabilities. And we have some data on that to share with you. That's the stigma and homophobia, which was quite thoroughly addressed, I thought, earlier. Third part is going to focus on working towards how we can define goals for a gay men's health movement. And again, I hope what I'll talk about will complement what was discussed earlier. And the last part will examine some of the opportunities that we have in the current environment that may provide leverage or further support for efforts for reaching the goals as you define them. So gay men have a distinct health. I just have to check that the slides did in fact move, because there's a mouse over there that apparently if it moves a fraction, this doesn't work anymore. Some people have questioned whether there is really any mandate to treat gay men differently from other men. And I would say fairly obviously, listening to the talk here, looking at the data, experience as a population, the prevalence of health conditions and risk factors does differ in many ways from heterosexual men. And as a result, the gay male population can be considered to have a distinct health status and distinct health needs that won't be met in sort of generalizable clinics or organizations. And this status then allows for an equally distinct assessment based on indicators associated with specific health conditions and risk factors at play. And such an assessment can reflect health status of the population at a specific point in time, and you can track it as well longitudinally over time to look at trends. And some of the health conditions and challenges that contribute to the new unique health status are the communicable disease, very specific disease and incidence patterns, HIV, syphilis, hepatitis C, issues of mental health and substance use which are connected to the personal experiences of violence, prejudice and poor self-esteem, and the increased, there's one specific cancer, increased incidence of anal cancers associated with human papillomavirus infection. And this is by no means intended to be a definitive or an exhausted list, and nor is it really meant to suggest that we should just focus on health deficits. In fact, I was going to propose as an accompaniment that there could be a useful description of an atlas of wellness and resilience could be developed as one of the outcomes as the health initiative for men. And I was glad to hear that that was also reflected. It wasn't just me, that was also reflected by both Brian and Philip earlier on. So, looking at sort of self-reported health status, these are data from the 2000-2005 Canadian Community Health Surveys conducted by Stats Canada, and they included a question that asked participants to self-report on their sexual orientation, as well as on a number of health-related conditions. This allows for an analysis that will build on an understanding of the differences in health-related issues between gay, bisexual and heterosexual populations. And these results do clearly indicate that for some health-related measures there are significant differences between these populations. For example, in terms of physical health, although the self-perceived general health of gay men was similar or slightly higher than that of heterosexual men, bisexual men were more likely than heterosexuals to report fair or poor health. That's fair or poor health here, you can see 12% versus 7.7%. Gay men tended to report living with more chronic conditions than did the heterosexual or bisexual respondents, and gay men are also more likely to have had at least one disability sick day due to physical illness in the preceding 2 weeks of the survey. And in terms of mental health, bisexual men were more than twice as likely as heterosexual men to perceive their mental health as fair or poor. And respondents were asked if they'd been diagnosed with a mood or anxiety disorder. Gay and bisexual men reported levels above those than for the heterosexual population. And the comparatively high prevalence of mood and anxiety disorders among gay and bisexual men was reflected in higher percentages reporting at least one disability or sick day in the previous 2 weeks from emotional causes. If we just switch now to look at some of the specific health challenges, looking now at syphilis, the outbreak of syphilis among men who have sex with men in BC, and in fact in a lot of other jurisdictions in North America, continues to grow. And this is that kind of downy brown coloured line up here from the 2002 through to 2007. And in fact, by the end of September this year, the number of syphilis infections identified had already exceeded the total number of cases for all of 2007. And currently, syphilis infections in men who have sex with men represent the vast majority of all reported cases in the province. And when we look at that in a little bit more detail and look at the connection of syphilis with HIV, these are BCCDC analyses. Here in BC, the majority of new infectious syphilis cases are among HIV-positive men who have sex with men, where they comprise about 64% of all cases in men who have sex with men, or about a third of all the provincial cases. Information gathered during case and contact follow-up suggests that it's sort of serosorting may be contributing to these trends, where men who are seeking out other men of the same HIV status for unprotected sex, and in this case it would be HIV positive men seeking out HIV positive men. And the sexual networks of men who have sex with men cases identify a concentration of HIV positive men within each of those network branches. And if you want more information on that, then Mark Gilbert is the guy to talk to. Other factors, of course, which may contribute to this include the transmission of syphilis through oral sex, because that's not a safe sex practice for the spirochete. And the key message here, I think, has to be to get tested and treated, and to be aware that even if one has been successfully treated in the past, reinfections can and will occur because there's no immunity. It's also really important to know that syphilis infections promote both the acquisition of HIV because of the vulnerability of the primary lesion, but they also contribute to the transmission of HIV because viral loads, HIV viral loads, go up measurably when somebody is infected with syphilis or indeed other STDs. Looking at HIV, since 2002, Two, the greatest number of newly reported, not necessarily newly diagnosed, but newly reported cases, again, are among men who have sex with men. And that's been going up overall year over year. And in contrast to trends in newly positive HIV tests among other populations, for example, injection drug users or heterosexuals, which have been largely stable or decreasing. And that I should note here, of course, that HIV tests reflect when the HIV is diagnosed and not when the infection occurs. We are trying in BC to get the resources to do some work that actually measures HIV incidence by looking at what's called a detuned assay. This work has been done in the United States, and data there suggests that the new infections, oops, have I gone in too far? Yeah, that new infections there are predominantly in HIV positive men as opposed to other groups. So we're looking at doing that work there here in BC, because it isn't a reflection of past infections which are suddenly coming to light. It's probably ongoing transmission and new infections. Another emerging health issue is hepatitis C, and there are increasing numbers of reports from Europe where they've identified outbreaks of hepatitis C through sexual transmission among men who have sex with men. In BC at the moment, we could sort of fairly confidently say that 80% of plus of transmissions of hepatitis C are actually through probably injection drug use and sort of blood sharing, whereas in Europe we're seeing the outbreaks of hepatitis C. We're looking at sort of disaggregating and examining our survey data on HCV in men who have sex with men, including analysis of hepatitis C and HIV testing in the M-Track, which also contains a quick blood testing serosurvey for HCV and HIV. And the data that we have, based on the linkage of our various HCV and HIV databases, is suggesting that there is an increase in hepatitis C in men who have sex with men who aren't injection drug users. That would be the orange bars. So we are, I think, highly suspicious of seeing an increase in hepatitis C sexually transmitted in men who have sex with men in BC. Turning to look at mental health, these are sort of data which confirm what the experience that people were talking about, that Brian and Philip were talking about, and the audience was talking about yesterday. This is from the Urban Men's Health Study. It's a population-based survey of men who have sex with men. The data are collected through a telephone random dialing technique, and looking at almost 3,000 men in San Francisco, Los Angeles, Chicago, and New York. In the late 90s, participants were asked about 4 mental health related issues: polydrug use, depression, childhood sexual abuse, and partner violence. And the results show there's high correlation between these 4 mental health issues among participants rather, suggesting that the idea that you've got intertwining epidemics of mental health issues, you're not going to have one mental health issue. These mental health issues sort of combine with each other. You have one, you're more likely to have another. I think a term for this that's been proposed is syndemics, as in synonymous epidemics. And the interpretation from this really would be that just focusing on a single specific disease, ill health entity, anxiety or depression or drug use, is not going to be as useful as trying to focus on an integrated approach that looks at dealing with some of the common determinants of the outcomes which are manifesting in sort of symptomatology or pathology or disease. And in fact, this study here, also from the same group, when you stratify participants by the number of psychosocial health problems that they reported, there's a clear gradient between the number of problems that they reported and both self-reported high-risk behaviours and HIV prevalence. So with no problems reported, relatively low high-risk sex activity, relatively low HIV seroprevalence. When you have 3 or 4 problems, you've got almost a 1 in 5 chance of being involved in high-risk sex and being HIV positive. We've also looked at substance use, and much of the discussion related to the use of drugs and alcohol has really been focused on how it may push or promote risk behaviours related to a variety of diseases through the medium of unsafe sex. And research done by the BCCDC looked at a cohort of gay men in Vancouver between 1997 and 2002 and did observe significant increases in substance use and unprotected anal intercourse with casual partners, which of course is a strong risk factor for HIV seroconversion. However, although the results indicate an association between club drug use and unprotected anal intercourse, the authors did conclude that it wasn't necessarily the disinhibiting effect of the drugs alone that could explain this, but it also depended on, obviously, partner serostatus, disclosure, and other close related factors. And in 2001, the AIDS Committee of Toronto conducted a literature review to examine drug use among gay men who frequent clubs or parties as part of the larger resource for community-based organizations, and they were kind of sort of able to disaggregate the rather simplest thing that you take drugs make you behave in ways that are risky, so that although in the drugs part of the party scene poly-drug use is common, usually with designer drugs and party drugs, it was a normative and expected behavior in that community, and it was rarely excessive. It was recreational and accepted. And although there is a link between sexual risk behavior and the use of illicit drugs, it's more likely that if you do the two things, you'll be doing them together rather than that one leads to the other. And it was also seen that it's a sort of collective activity, and that driven by social networks, and that was the best source of knowledge around how to moderate or modify drug use. And looking at some data from BC on crystal meth use, we can see that over that same period of time, just as sort of crystal meth hysteria was starting to ramp up in the newspapers, you probably remember this about 5-6 years ago when all of our schools were being decimated by crystal meth in Surrey and Abbotsford and places. Actually, use among the gay male population in British Columbia was declining, and I think it's continued to decline. And I think this was a pattern that we were seeing across a whole variety of populations in British Columbia. Just again, looking at another sort of risk outcome, although the incidence of anal cancer in males is generally pretty low, less than 1 case per 100,000. It is a sexually transmitted infection, human papillomavirus. We don't have Canadian data currently, but we do know that certainly in the US, rates of cancer and HPV are much higher in gay men, and particularly in HIV-positive gay men. We do have a screening survey underway through the MTRAC in Vancouver, which should give us some sort of Vancouver-specific data on that, which I think will be really useful in informing development of sort of detection programs, as well as potentially prevention programs. And if we know that the HPV strains are potentially the same as are found in the quadrivalent vaccine, then we'd be building support for preventive HPV vaccination in men, in gay men or at-risk men, as well as in women, where we currently just initiated a program for young girls. Switching to some of the social factors that influence gay men, I won't spend a lot of time on this because I think it was dealt with far more efficiently and effectively than I could have earlier on this afternoon. But obviously the issues of stigma, marginalization and homophobia, some of the shifts in how gay men define community and connect with each other, maybe some of the unintended consequences of the broader presence or visibility of social issues related to coming out, and the influence of political environments. All of them were touched on, so I'll try not to be repetitive, but just to add it where I may have some additional new information. Stigma, marginalization, homophobia, violence are clearly not not things of the past. They're really quite current, and some of these headlines sort of really emphasize that. And the issues of stigma, marginalization, homophobia, heterosexism, you're more familiar with those than than I am. So again, I won't sort of belabor those points, other to say that environment, that growth environment, clearly influences how people feel about themselves, about each other, and end up, I think, diminishing potential health status. And the experiences clearly can result in lowering self-esteem, higher rates of eating disorders, problematic alcohol and substance abuse, depression, heightened levels of anxiety, and right at the end, to suicide and self-harm. And we know this is happening in BC as well, because the McCreary surveys of the adolescent health surveys, which have been done in 1992, 98, and 2003, consistently have asked the same questions of youth. They ask them to define their sexual identity based on feelings of attraction to other people that could best be described as 100% heterosexual, gay and bisexual, mostly heterosexual, bisexual, and mostly or 100% homosexual. And in general, across those surveys, lesbian, gay and bisexual youth are significantly more likely to report the risk factors, health conditions and environmental influences that are listed on this slide. So they're more likely to report running away from home, more likely to report early intercourse, increased number of sex partners, more likely to be engaged in other risky behaviours, more likely to be depressed and attempting suicide, much more likely to be subject to sexual and physical abuse, much more likely to be victimized and discriminated against school, and so tragically less likely to report being involved in the school process, to feel supported by their parents or connected to their families. Everything was talked about earlier. And while we note that there are some sort of nascent programs in schools in British Columbia, I think I would share the conclusions of the speakers earlier. They're not enough. The dosage isn't sufficient. They're not really followed through strongly enough. And we need to really change those school environments if we hope to make a difference. So, just a little bit on internet partners, because people talked about the virtual world, and I guess if that's the virtual world, this is the analog world, and people are sort of moving more into the virtual communities and away from physical community space. This just shows self-reported use of the internet to find partners among gay men in BC, and again, this is just BC data. I don't think I could add much to what was talked about it earlier on, other than I was really pleased to learn about the Health Initiative for Men having acquired the, I guess, was it the rights to Vic Vancouver, and doing kind of viral marketing of that and linking it with Facebook, etc. Because I think from a public health perspective, we need to engage in those virtual social networks a lot more strongly than we currently are, to sort of put out positive messages, education, etc. And one example of that is the e-card, which enables you electronically to inform your partners if you've gotten one of those nasty telephone calls after a visit to the clinic. Right? It was launched in San Francisco in 2004. Apparently it's had about 30,000 people using it to date. The Canadian versions have been launched in Toronto and Ottawa. And they've actually been very low reported levels of abuse. You might think that, I'm going to play a joke on somebody, I don't like so-and-so, I'll send them the card. But apparently that doesn't happen, or it hardly happens. And the uptake is good. I guess it's probably something you don't want to necessarily put on your Facebook, but other than that, it does seem a good way of sort of reaching out and talking to people about discussions that can otherwise be somewhat difficult. But that move into the virtual world has sort of been paralleled by a little bit of lower connection and affiliation with the gay community. So that presents challenges with the physical space and the face-to-face thing, and you have to ask whether the virtual community can sort of replace, or how the analog community and the virtual community can link themselves and work together. And what does this mean in terms of sort of developing and maintaining and building gay social capital, which is clearly one of the critical things that HIM is intending to build and wants to strengthen, both between its members and then between its members and the broader communities. We talked earlier on as well a little bit about some of the unintended consequences of greater visibility, and and the fact that this fight for marital rights, equal opportunity, doesn't actually end there. It may put additional pressures on people. But there's also an issue, I think, that was talked about earlier on, where, you know, if we think everything's okay and we encourage people to come out, but we're not ready with the supports to protect them, and we haven't dealt with the homophobia or the viciousness or the violence that can accompany that, then you really are in a quandary as to tell people how and when to come out and how that can happen safely. And I would be really worried to think that, you know, with false advertising we had encouraged people to come out into environments which were far from receptive to that and were quite hostile to it. And in fact, if you look at the unintended consequences, this is from the Urban Men's Health Survey, and it actually stratified individuals into when they came out as gay, whether it was a what's called early, middle or late achievement of gay coming out milestones. And in fact, the earlier people came out, the worse their self-reported experiences of harassment and victimization, which again I think should cause us to step back a little bit and look at those environments and figure out what to do about them. And if you look again in a different way at the developmental profiles of health of gay men, if you look at issues of partner abuse or victimization or depression, HIV or polydrug use, the earlier people came out, the higher their subsequent experiences of those, presumably modified by the fact that they didn't have the defensive or the supports to sort of push off and defend themselves against the discrimination that was inflicted upon them. Our political environment doesn't necessarily help. I mean, I thought in the last election, both sides of the border, we've seen wedge issues used to leverage political support from a core political group, and whether that's been abortion or anti-gay marriage or anti-harm reduction, it clearly, you're a community who can clearly be used in wedge issue politics. For example, it wasn't that long ago that Surrey School Board spent millions of dollars trying to keep blue dads out of schools. I mean, how ridiculous was that? But it obviously served the political purpose at the time. So, where would a gay men's health agenda need to go? There are some specific and significant challenges, but on the other hand, as was mentioned earlier, this community has significant strengths and resiliences that serve to mitigate and give me confidence that these challenges can be overcome. I mean, you don't have to look back very far to see how the entire response to HIV, human rights, etc., was challenged by an organized, very verbal, intelligent, active gay community in the 80s, and formulated a complete sort of political response to a disease which was unfortunately sort of targeting that population. And so that strength and capability and capacities are there and need to be mobilized to sort of move that shared vision, which I think was explicated really well by Brian earlier on this afternoon. So in shaping the vision, it's obviously going to be helpful to consider what's required to foster a more positive and healthier environment for gay men. And speaking gay men specifically here, but obviously for broader, you know, if you can create a healthier environment for gay men, you're going to create it for lesbians, for bisexual, for transgendered, for two-spirited. You can address the racism and sexism as well. Where gaps exist in programs and services, and how can those gaps be most effectively addressed? Who are the leaders and champions that you can find to advance that vision, and what opportunities exist that may be helpful or that could be sort of built on? And there is a framework presented, Determinants of Gay Men's Health. I don't know, is this as particular to him, or is this a more generic framework presented here? And three sort of cross-cutting themes here: social and physical environment, social support networks. Any population health approach is going to recognize those. It's a sort of generic population health approach looking at the determinants of health and supports. But I think that there are some very specific conditions here on this cross-cutting theme around that very vulnerable area of time of coming out of emergence and recognition and forming and expressing a sexual identity in what can be a very hostile environment. So, going back again to looking just at HIV as a particular entity, I mean, the disease focus that we've used to try and prevent HIV since the early 1980s clearly hasn't worked that well. We need a different approach and a broader approach. I think we need to root it in theory, the theory that we've been talking about this afternoon, and broaden it out. A broader approach to HIV prevention that's more holistic, that affects and addresses the structural factors that have an issue and influence on the health of gay men, stigma, homophobia, cultural norms within the gay community that were talked about earlier as well, and look at that broadly into the community as well. So it's not just HIV, but it's other health vulnerabilities we're talking about. Now, some of the opportunities that exist in the broader context, not necessarily related specifically to gay men's health, are, if you've been sort of following Julio Montana, president of the International AIDS Study, you'll know that he's got a very broad, ambitious agenda to try and expand highly active antiretroviral treatment into broader communities. Currently, about a third of people who are eligible clinically get the drug, which is free. I think if we gave it to everybody, if we could get it to everybody who was clinically eligible, we'd probably double that. And that would have a major impact on some of the mortality and morbidity rates that we're seeing out there. But to do that, we have to create a much better infrastructure to reach out to people who are marginalized, where the big gaps in the system exist, and that exists for gay men, as well as for injection drug users, as well as for sex trade workers, as well as for Aboriginals. There is a mental health and substance abuse plan in the works, a 10-year plan, and that needs to be sort of factored into the thinking and the linking with him. I think there's a general support at the moment of government to push for prevention and health promotion. It may be based on rather simplistic initiatives that if only everybody ate well and exercised for 40 minutes every day, we'd all be sort of out there and healthy. It doesn't really recognize the determinants of health. But if you could bring those determinants into it and sort of capitalize on the interest and the focus that is there with the creation of a new ministry, of which I'm a part, I think that's an opportunity as well. And I think there could be other issues that we could potentially look for linkages with, as well as the whole concept and the focus of him expands. So I'm going to end there. There was one thought that obviously there is no magic bullet. There's no one thing that's going to solve problems, but the magic bullet originally started off being called a silver bullet, and apparently the silver bullet was first referenced by Ehrlich, who was a physician who, back in the late 1800s, early 1900s, was treating syphilis. So we came back to syphilis, which is where we started, and he was treating it with salvarsan, which was a silver arsenic mixture, which he thought would fix the problem. Obviously it didn't. So I'm looking forward to, I would actually like to work with you and him as you develop your programs and your processes, and would work within the ministry to do what I can to support that. And thank you very much. That's it.
We have time for one or two questions, and maybe I'd also ask the members of the sort of closing panel if they want to come up on the stage while we're taking questions for Perry.
Hi. Thanks a lot for the presentation. It was awesome. And I guess the thing that caught my attention the most was actually your final comments, which were that that you're interested in looking for opportunities to work together, and that's, I think, really important to us. And I'm wondering if, from your perspective, if you could identify one or two sort of strategies that community could use, should use, to engage with sort of upper level bureaucrats in the government and in the health field.
Okay. Well, I think I'd look back to the 80s, to the strategies that were developed then, sort of working through DHAVA thing. I think, though, that you actually got quite a core of support within ministries of health now. I think with current sort of governments looking at the prevention agenda and the return on investment for investing in prevention works. I mean, equity may not be the one that carries the day, values may not be the one that carries the day, fairness may not necessarily be the one that carries the day, but a return on investment is always one that carries the day across the country. I think in any in any of the political arenas that I've looked at. So working with the folk who you can identify as allies and creating allies outside of that group as well, and looking at opportunities to connect with political directions or pushes that are already in the way. And I outlined sort of 2 or 3 potentially that you could link with. And also demonstrating results really helps.
I just wanted to know if are there any specific examples of how the shift in the community is affecting gay men's health? Like, how is the definition of community affecting gay men and their health? If there is one.
I would look to I would look to some folk out there, in fact, to answer that question more than I could. In fact, I'd look to the audience to answer it, because I think you got into a really interesting dialogue about it, which went to levels of sort of depth and that I couldn't get to. I was informed and educated by that dialogue rather than contributing to it. So, but no, Mark.
Yeah, I mean, I guess I would just comment that I don't think we're at the place yet where we actually have sort of the results around, well, this is how the community is changing and this is what the impact it's having on our health. I think we're just beginning to hear concerns about the impact it might be having. But I think that may be part of the research or the evidence that's needed as we try to make a case.
You mentioned the development of a mental health and substance abuse plan, a 10-year plan. Is that available to the public yet?
No, it isn't. It's still one of those policy initiatives. It's a sort of throne speech commitment. I think a lot of the commitments and programs that have been made, which were sort of in the pipeline, if you like, I think that the economic turmoil that we've heard about in the last 2 months has thrown revenue projections off considerably. Mm-hmm. So I think it's fair to say that government and every ministry is now at the process of thinking, geez, what are the revenues going to look like next year? What are our priorities? What do we bring forward? What can we afford to do, right? How do we maintain? So strategically, for a particular issue to move forward, I think it needs to be linked with as many other political priorities or groups as possible, so that there may be strength in forming partnerships. So that if you've got a policy or a program that can actually link with 3 or 4 or 5 or 6 throne speech priorities, that's a good way of keeping sure that something stays on the agenda in a time when I think resources are actually going to be very constrained.
But if you're talking return on investment, as you just aware, in the addiction area and mental health area, there's so many programs that are just wasting money because they're not integrated and they're not connected to each other and people are falling between the cracks. Is this plan looking at that, looking beyond the public sector to the resources that are being poured into to these areas from the private sector for money-making purposes, and hence often abusive.
Yeah, we've been trying for actually quite a long time to import best practices into what's currently being spent. I think Vancouver Coastal has done a better job than other health authorities, to be honest. It's an area where BC is not particularly strong or particularly rigorous, and I fully agree with you. We're not nearly there yet. You know, some of our practices are clearly shown to be ineffective. It's a battle. I look forward to working in partnership with other people who want to bring that point up.
Well, I'd like to have your business card because I've been looking for people to nudge for a long time.
Okay, and you should also be talking to Patrick Smith, and there's a psychiatrist called Michael Krantz, who's a leading edge scholar at UBC from Germany, who'd like to work with you on that too, I think.
Okay, thank you.
Okay.
I have one more question. Is there time?
We're out of time, but it's a quick question. Go ahead. Oh, with Philip, there's nothing quick.
Thanks, okay. I'm just wondering, you know, Bill Ryan sort of talked about sort of the two major areas that we need to sort of approach this work through, and then health and education. And I'm wondering what kind of influence, sort of as a provincial health officer, you might have, or sort of the health bureaucracy or the health system might have, to address epidemics of violence that are having huge impacts on, say, kids in the school system. Like, where do those links get to be made?
Yeah, I was asking myself that when I was listening to the presentations and the discussion earlier this afternoon. I did do a couple of reports on health promotion in school. One was way back in 2002, which looked at broad opportunities that were being missed for sort of promoting health in kids from kindergarten right the way through to graduation. And some of that was picked up by the Ministry of Education, and they are doing better now than they were doing in 2002, but they still have a long way to go. I actually just had a discussion with Mark earlier on asking me if I'd do a report. My major way of doing this is to produce reports and push them out there with evidence and recommendations. Suggested that we do a special report on sexual health, on the formation of sexual identity biologically and socially, and then what happens in schools and how and when. And that might be a way of trying to address some of these programs. As you probably know, even teaching sex ed to heterosexual kids is fraught with difficulties. So, you know, how do we push it across for all children and make it a healthier experience developing a sexual identity?
If we can quarantine folks with TB, can't we quarantine homophobes?
I'll think about that. Thank you.
Thank you again, Dr. Kendall.